Datuk, semua dah masuk ya?
Nama sudah.
Ya.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, petang ya. Petang kan?
Ya, petang.
Okay, our topic given today is respiratory examination. So, tengok gambar tu kan. That is children all about. Nampak sama size dia ada gambar tu. Tapi the size are so different. Maturity is so different for infant, toddler and children, child. So, very challenging. And like adult satu size dia. Betul tak? Adult mainly the length cuma gemuk tak gemuk. Itu sajalah. Most of the time they are same size. Increase the length sama. Tapi children very challenging. Is from the baby until toddler until the 12 children, child, and even one day adolescent will become under pediatric. So quite challenging in pediatric. So that's when the skill in pediatric is just not ability to examine, but also ability to adapt. How to have the maximum information, gather maximum information with the techniques that the same techniques you do either in small children or in adult. Respiratory system is many functions. It is breathing and gas exchange function, defense function, metabolic function, depositor function, so many functions. But mainly is the breathing and gas exchange functions. The rest is not a major function, but it still can affect the body if it's not functioning very well. But the breathing and the gas exchange is the main function in the respiratory system, and many of mobility and mortality due because failure of the first function, breathing and gas exchange function. So the aim of this lecture is to understand the basic physical examination, to know the proper technique, to recognize normal and abnormal finding, and to be able to do clinical conclusion. Usually, during my previous teaching, I give a lecture to the whole class. Then after that, I select one student to become a sample, or what I would call it, sample nama dia. And I'm going to do the physical examination on that. Usually I choose the smallest student out of you. 30. How many of you? 34?
Yeah, 34.
34. So who's the smallest there? Male. Usually I take the smallest one of you, then I will do the physical examination and edit it within 10 minutes for you to see the proper techniques. I don't know how to do it now because of this COVID issue, and hopefully we can sort out the COVID issue, then we can do proper teaching properly. Because talking in the lecture and what you do, what you practice on your patient, starting with yourself, is different. I can talk 2 or 3 hours about the physical examination, but then if you are unable to do it on your patient or unable to simulate it in your patient, I don't know how you're going to get any benefit from this lecture. But we try our best, because physical examination is the best is you do it on your patient, thus you know how to do it. This is the technique. Because our motto is that if the technique is not good, you won't get a proper finding. That's all. The key of any finding in physical examination is a proper technique. So as I repeat again, the aim is to understand the basic physical examination, to know the proper technique, to recognize normal and abnormal finding, and to be able to do clinical conclusion. Respiratory system, you know, in children, even in adult, consists of upper respiratory tract and then lower respiratory tract. your the dividing border is your, they call it tracheata. When you put your hand to the old trachea until you feel the trachea enter the chest, enter the chest, they call it. There is the you put the hand on your neck, you follow your trachea until you feel the trachea enter the tracheothoracic inlet. That is the border where we decided the upper airway and lower airway. Those above the inlet will be the upper airway. Those lower the inlet will be the lower airway. So the larynx, 1/3 of trachea, nasal cavity, pharynx, epiglottitis, the the hypolarynx, all of this is a upper airway, whereas the trachea, the lower 2/3 of trachea, the bronchus, and the lung, pleural, all these are lower airway, and also the bronchioles, alveolar sac, and so on, lower airway. And then remember that you're talking about the respiratory system. Don't forget your muscle. Muscle are very important component of respiratory system, in which without muscle there will be no breathing effort. The muscle including the principal muscle, which is intercostal muscle, and the internal, the external, and the costal muscle, and then the diaphragm. This is the main muscle, respiratory, and then the accessory muscle is sternomastoid, and the skeleton group of muscle, and the pectoralis major. So very important to remember the muscles, and then remember that in respiratory breathing movement, they got two, inspiratory and expiratory. The inspiratory is the active movement. It means involve the muscle contraction, whereas the expiratory is the passive, which the muscle didn't contract anymore, and the muscle go back to the inert position by itself, usually by the gravity. Then the child expired. Inspiratory is active, expiratory is not active. Remember that. And when you examine your patient, you must know what you touch. Very important. No point you touch, you don't know what you touch. You just see the skin, you thought that you touch the skin and that's all. But it doesn't work like that. You must know what is the underlying of the thing that you touch. So you must understand that this is your thorax, patient, and you look inside there. There's the lung, left lung and right lung. You know there's upper lobe. You see the respiratory, the lung is from here. The lung component is from the apical until into the 6th intercostal space. In 6th rib. Below that will be the pleura, 7. So your lung is 6 and above. And then remember that the anterior of the lung, it is on the anterior side of the lung, on the right side, there is the right lung got 3 lobes. So the upper lobe, middle lobe, and lower lobe. So the upper lobe, the fissure, the dividing the upper lobe and lower lobe will be at the 4th rib. Whereas the oblique fissure, divided the middle lobe and lower lobe will be the extension from the 5th to the 6th rib. Then this one. Whereas in the posterior, you found out on the right side, all is upper lobe and lower lobe only. And so are in the left side of the lung. So left side of the lung, the upper, the only 2 lobe, upper lobe and lower lobe. So the 5th into the 6th is where the fissure that dividing the upper lobe and the lower lobe. So but the posterior, remember on the oblique fissure on the 4th rib, 1, 2, 3, 4 rib is the upper lobe and lower lobe. Remember that. So whenever you touch your patient, you know what what is the lung underlying of it. When you auscultate, you know which lobe you auscultate. You have to figure out, we have some ideas which lobe that give you the sound. So this example, upper lobe, middle lobe, upper lobe. So this upper lobe and lower lobe. Upper lobe, this middle lobe, lower lobe. And then this at the back will be upper lobe, lower lobe, upper lobe, lower, at the fourth. And then this lateral side, upper lobe and lower lobe. So here, the middle lobe stop here. Is those adult is still practical for the children. And then you know what the lobe is, but the other thing you must understand that when you examine, you always remember the upper zone, mid zone, lower zone, upper zone, mid zone, and lower zone. We talk about that later. So when you understand the anatomy, so you give you some ideas. Whenever you touch your patient at the chest, you know which lobe, and you know that which lobe involved. A second thing, is there a lung tissue there or not? It gives you some ideas. So you know if you auscultate here, you know you auscultate the upper lobe of the left lung. You auscultate here, you know you auscultate lower lobe of left lung. This one, right lung. And so it gives you ideas, because any abdominal sound originate that you listen here tell you where it's originated. Give you some ideas. So talking about physical examination, is involved inspection, palpation, percussion, and auscultation, and usually after you took the history taking. Because history taking are the most important because it tells you what, where, and where to do, what to do, where is the thing that probably the problem are. So the step, you must remember this always: inspection, palpation, percussion, and auscultation. And before examination, as always, you have to build rapport with the child and with the parent. That is standard practice. You can't examine any patient if you don't have rapport with them. You have to have a rapport with children. In children, you have to have rapport with their parents, because if you don't have rapport with your parents, the children will become easily agitated and more hostile to you. You have to understand children, they sense if you are unable to make rapport with the parents. They sense something is not right and they are not going to become cooperative. And as usual, please clean your hand properly and wash your hand or use the hand scrub with proper techniques. Very important. So you are clean yourself, you don't transmit anything to your patient. And the position, the key position examination of the chest is the most important, the more comfortable to the infant and the child. There's no standard practice. In adult, there's standard practice. It must be in 30 degrees and so on. But in children, you want them to be the most comfortable. If you can have a proper position, is good. It is cooperative. But if not cooperative, especially small children, then you get the best position. They are very comfortable in such way they able to cooperate with you. Remember that. And then proper exposure. And if possible, do a proper exposure of the chest. Very important to look at the proper exposure of the chest and examine the anterior of the chest first. Examine anterior chest position first. Then after you examine the posterior. So in position in child, infant can be at the cot or bed. Small children, if you can have patient lay in the bed is good, but if not, sometimes they would prefer you examine them at the mother lap. If not, they're not going to be cooperative. Bigger children, yes, they are quite as cooperative as adult, then you can examine them properly on the bed. Remember, no sitting examination in children. This adult, they encourage sitting, but in children, we don't encourage sitting. Bigger children, if you can cooperative, you can examine with 30 to 45 degree position. No sitting. And you always start with inspection. Remember, always start in inspection. What to look at inspection? Look at the alert conscious level, standard, nutrition status, dysmorphism, hygiene. You tahu dysmorphism apa? Anybody knows what dysmorphism is?
Down syndrome.
Dysmorphism is abnormal feature. Doesn't mean Down syndrome only. Any abnormal feature that you can observe or you can see on the patient when you examine the patient. Dysmorphism. Look whether cyanosis or not. Very important if the patient is in respiratory distress. Evidence of respiratory distress is tachypnea, subcostal recession, intercostal recession, trachea tacks, breathing sound, wheezing, stridor, glottal, or grunting. And you look child with respiratory distress, you can look frightened face, skin is pale, there can be sinus, flaring of the nasal, it can be a cyanosis, skin at the neck can be pulled up in when the child breathing. So intercostal recession in the neck, we call it a trachea tach. When you inhale, there's the inlet of the trachea goes in, trachea tach, and then there will be a rapid belly nafas using the abdomen. The example of child respiratory distress. And remember, respiratory rate in children are different according to the age. The younger they are, the faster their normal respiratory rate. The older they start to, usually above 6 years, they start to become like normal. 12 years old, they have normal respiratory rate as adult. So different, remember that. And then after you observe the one examination. Okay, and then after you do the observation, inspection, then you start to do the palpation. But in palpation, you must know what you touch lah. So in palpation, in the lung, you have to divide the lung into the upper zone, here, middle zone, and lower zone. Upper zone, usually second intercostal space and 4 intercostal space. 4 rib, second rib, and 4 rib. Because at 6 rib, it will be the lower part of the lung already, lung tissue. So the upper, mid, lower zone. We call it zone. So when you examine, so you know, postural is the same. So you look at upper, mid, and lower. So you know at the upper is still the upper lobe. The mid zone, you can probably examine the upper middle lobe, lower zone. At the anterior can be the lower, middle lobe, and lower lobe. Whereas at the left side is different. So upper lobe, and lower lobe. So posterior, mainly the upper lobe at the lower upper zone, middle, lower, mid, and lower zone will be the lower lobe. Same on the left side. So this is because you need to divide by the zone, so you know how to auscultate systematically or to examine systematically. So when you observe the chest shape. There are many shapes of the chest in children, and then many shapes. So many to talk about the shape, many shapes. I like adult. Many shapes. This is very abnormal. Because sometimes we cannot define it. But basically it's same. This is vectors. Apa ni? Anybody knows?
Excavatum.
This excavatum. This vectors.
Carinatum.
This one is what? What you notice? You can see the depression here is a Harrison sulcus. When the diaphragm works so hard, result in the depression on the lateral side of the chest, where there are the insertion of the diaphragm muscle. So you can see the depression of the lateral side. This is horizontal sulci. This apa ni? Sebiji. This chest deformity due to rosary rickety, due because vitamin D deficiency. And this one, anybody notice what is this? This lung hyperinflated chest, due to because severe asthma. Chest is started with normal, but because chronic severe asthma result in barrel-shaped chest. In adult, probably you put it as COPD. So AD, but in children is due to uncontrolled, poorly controlled asthma result in hyperinflated chest. So remember, at the same time, after you look at the anterior, when you examine the posterior of the chest, you also look for the kyphosis, scoliosis, check the spine, and then any scars at the posterior wall, chest wall. Anterior chest wall, you look at the anterior chest wall, the ribs, sternum, and the posterior chest wall is the spine, and the scapula. So this, you see the respiration, observe the respiration rate. If you little bit about respiration, seesaw, usually normal respiration usually is expansion of the chest. You take the breathing and then the abdomen is go in, the inspiration, but expiration, the abdomen go out, chest go in. Tapi in seesaw paradox movement, the chest falls to inspiration and rise to expiration. It is a terbalik, reverse from the normal respiration. So it's called is due observed respiratory failure. Because small breathing is patient passing, breathing very fast, gasping, labor breathing, usually is due diabetic coma or respiratory acidosis, mainly the acidosis condition. And the one change stop breathing, where is the breathing is high, fast, and then become low, the frequency, fast, low, the change stop breathing due to brainstem injury. That is the thing you observe and you calculate the rate. And then for patient, start always with general examination. And in our country, you start with the hand first. Look for clubbing, pill. If the child perfusion, pulse rate, because your child is increased pulse rate, his child is not well, fever or not well, hypovolemia. Head, look at the head. I mean, especially the eyes, the conjunctiva, pale, polycythemia, central cyanosis, and the mouth. Remember, mouth is also part of the respiratory system. Look hygiene of the mouth, cyanosis or not, tonsil, the tonsil here too. As you look here, the tonsil are enlarged and red. So this patient both having tonsillitis and pharyngitis. Large and red. And then before you start second episode, you want to go for the chest, palpation of the chest. You try to not only for the zone, then you also look into few things, the imaginary line to help you to give you some ideas where you are. For this is the parasternal. This is parasternal fossa. As I mentioned to you, when you look tracheata, there is the thoracic inlet that divide the upper airway and lower airway. Here is where tracheata, you can see the depression during the inspiration that give you information that the patient or the child having this distress. So this the supraclavicular fossa, the suprasternal fossa. This is the line, anterior and midline. There is the sternal line, there is parasternal line, mid-clavicular line. And all this give you some ideas where you are. Mid-clavicular line, this middle clavicular line, parasternal line is just beside of the sternal line. Sternal line is at the side is sternum, and at the lateral to it is sternal line. Give some ideas. So when you describe your finding, people know what you're talking about. So at the back, posterior midline, scapular line, interscapular region, suprascapular region, infrascapular region. So you know, if you say that there is decrease a scar at infrascapular region, so people know what you're talking about, the location. So in palpation, when you want to palpate the chest, but start with the trachea, I don't know, you have to use a 3-finger technique, 2-finger technique. Don't know how to show to you. Trachea, you palpate the trachea first. In bigger children, you use 3-finger technique. In small children, you use 2-finger technique. It's two different things. And then you, at the same time, remember that lymph nodes is also part of the respiratory examination. You have to know where the lymph node is. This submandibular, submaxillary, this the anterior sternomastoid, posterior sternomastoid occipital. You know the lymph nodes. This is subscapular, is subclavicular, is supraclavicular. So you know the group. So when you palpate the lymph node, you palpate from the back, go up behind and so on. So feel the lymph nodes, and you know where the region is. You can describe the lymph node finding, and after you do the trachea, you do the lymph nodes, and then very important is to know the mediastinal movement or not. You know mediastinum, what mediastinum is? Is where your tak ada gambar, lupa ada gambar mediastinum. You do the mediastinum, and then the mediastinum is the way you want to know mediastinum shifted or not. You do the apex beat. At the apex beat is usually at children 4th intercostal space, lateral to the mid-axillary line. So lateral to lateral to mid-scapulacular line here, 4th intercostal space. That is where the normal place of the apex in pediatric. So it go down here. It doesn't mean in respiratory system, that doesn't mean cardiomegaly. It can be because of the shifted of the something happen on the right side or something happen on the left side, make the capacity displaced, or it can go inside, medially. It goes medially. It means that it's been pushed here medially. What it shows that something is happened to this lung here or this lung here, that made this shifted of the mediastinum. Mediastinum is here, the region inside here, between these two lungs. The gambar lung. So this is a mediastinum. This mediastinum region, we call it mediastinum. So the apex beat here, if you locate here, I mean there's some movement of shifted of mediastinum. Something happened to the lung, both sides of the lung. If you be aspect usually here, you move inside, so this also something happened that made the movement of the apex beat. So the mediastinum, the trachea is here. Sometimes the trachea move to right side, so it tell you the mediastinum is moving on the right side, left side. If the trachea move on the right side, it tell you the mediastinum move on the right side. So they have name. So you know the position of trachea, tell you where the mediastinum is. So then you do the vocal chest expansion. You have to put both of your hand on anchor. Tak ada gambar, tak ada ni. Chest expansion maknanya. You have to, we talk about it later. Chest expansion, you do chest expansion. You do chest expansion, you have to do the upper zone, mid zone, and lower zone. You have to do the upper zone, mid zone, and lower zone, chest expansion. So you have to position, you have to use your macam mana nak foto ya. Macam nak buka ya. Sekejap. Okay, gua nampak. So nampak tak? Ni, you have to use your here, little side of your here. Siapa nampak ni? For your lateral side of your knee to do chest expansion, you put it at your sorry, that is vocal meters. Sorry, chest expansion you have to anchor. You have to use your knee. Sorry, chest expansion you have to use your thumb. Thumb. So you have to use your thumb. You have to anchor it at the upper zone using your finger here. Anchor it, and then you put it on the chest and ask the patient to take a deep breath. So the hand will move. The finger will move, and the difference in the movement, the jarak, the length, the gap will tell you the estimated of the chest expansion. You have to do the upper zone, mid zone, and lower zone. Okay, upper zone, lower zone, and mid zone. I think simple, which same with adult. But remind you, sometimes the chest of the children are very small in baby. How you do chest expansion in baby? Usually we don't bother to ask you to do, because you want to do your hand already dah full. Satu tangan pun dah full of the baby chest. It's not easy to do chest. So you look, you observe roughly, you can figure out already. So it's not something that is a must in children. You have to decide which can be done, which cannot done. And in children, you must realize at 2 years old, you put your hand on the chest, already the child start crying. Not nobody's business. So you defeat the purpose of examination. So you have to adapt. You want to, it's bigger children, not much a problem. But in smaller children, you have to decide, is it advisable to do or not? There is the chest expansion. So, okay, after you do chest expansion, you do the vocal perimeters. Vocal perimeters, you use your back of your lateral side of your hand. You put also at the patient, at the children, upper zone, mid zone, lower zone, and you ask the patient to use the word 999. You put there 999. You feel the vibration 999, 999. You feel the vibration, and this this something is the technique that you have to have the skill to do that. Because you have to know what is a normal vibration. It means that you have to practice among yourself first. You put it upward and lower 999, and you can see the vibration, and the vibration will tell you it is the vibration will tell you because it depends on the sound movement. So in solid condition where the sound movement are faster, the vibration increase. So in water condition where the vibration they do not a good the sound didn't move very well, then sometimes you don't feel the sound vibration. You don't feel it. So then it tell you that something is not right. But first of all, you must understand what's normal sound vibration in the chest. You have to practice among you all. So, but then still I have to remind you, it's not an easy thing to do for small children, that infant and then in the toddler, especially if the child not cooperative. So still an option to use, to do or not to do, but still you have to know as an adult, you have to know. So another one will be percussion. Okay, percussion, the most important is the technique. So very important percussion, though, the technique is that in the middle finger, it must be held firmly on the surface, where usually the left finger, and the right finger will hip 90 degrees. So you can hurt there 90 degrees. So if you're good enough, any surface you use will be different sound. You can practice on your own. You can practice. You can percuss the table, the wall. You can see you can feel the difference in sound. So the important is about the sound. So you see the technique. Then you must, but still you have to know the normal sound, resonance. So you have to practice on your own, on your patient, on yourself or your friends to know this is normal. Only then you know the abnormal sound. The abnormal sound will hyper resonant. It means that they increase in the resonant, and dull. Dull is very flat. Like this one, ascatic the table is dull. What dull? There are many types of dullness. They are what we call it liver dullness, the consolidation dullness, and fluid. Fluid, very, if you profusion with stony dullness. You know, you got percuss stone. This is like that, stony dullness. Dullness. So when you percuss, you remember there are where the sounds are. There is the chest. You can look here. There are cardiac dullness here, and there is liver dullness. The stomach pun bunyi lain. Kalau you percuss your stomach, the tympanic, the sound it, and then the rest of the lung will be resonance. So are at the back. Resonance, what can be dull here. And then resonance is low pitch sound, heard normal lung. Hyper resonant is a loud sound that resonant than normal, heard over hyperinflated lung, such as in acute asthma case or in adult COPD, or tympanic drum-like empty quality heard over the gastric intestine, stomach, or in the pneumothorax. Dull is medium intensity pitch sound, duration heard over the solid lung, solid lung, solid tissue, which will tell you the consolidation, fluid space. Tapi this one tak payahlah. The other one, dull, is the stony dullness. If fluid fusion, you can feel the percussion is like a percussion wall, very stony like. And then how you do percussion? First, you percuss the upper zone as usual, lower zone, upper zone left and right, middle zone left and right, lower zone left and right. Compare the left and right. Then after that, you percuss every intercostal space from right down, left down, and in bigger children you can decide to percuss laterally. But it's not optional. First you percuss, compare upper zone left and right, upper zone left and right, upper zone left and right. Then after that you percuss every intercostal space. But when you percuss, you must realize that when you certain place you can feel some cardiac dullness, very little bit dull. Here you can liver dullness, very quite dull at 5th intercostal space and below. And then resonance. And then here when you percuss here, you can listen to the stomach tympani. And here in posterior side, in posterior mostly to resonance. Okay, in adult, when you percuss in between the interscapular space. But in children, you just percuss, doesn't matter. you just percuss even above the knee because the bone are thin, and second thing, very little space for you to percuss. So you just percuss continuously, run through the bone, on top of the bone. It's okay. Then the last thing will be the auscultation. So using your stethoscope, and you know your stethoscope, is it? You got stethoscope is this one is this is your bell, this is your diaphragm, and this is your bell. This is your bell, this is the diaphragm. You got two part component. And stethoscope, remember, children, they are infant stethoscope, there is a pediatric stethoscope, and adult stethoscope. So you have to use proper stethoscope for proper patient. Remember that. If not, you cannot optimize the proper. I know for you all, for training purpose, you can use adult stethoscope for a while, but when you practice, you come to the pediatric, you better use proper stethoscope. If not, if you use infant stethoscope to bigger children, you don't listen, you cannot hear anything. So stethoscope is to listen to the breathing sound. And when you auscultate the lung, always use the diaphragm. Always use the diaphragm. And for the beginner, for you all, always use the diaphragm. And then you hear sound from the lung. What do you listen? Usually A entry or A movement in the lung. So you have to decide, is it normal, decrease, or no A entry? Type of air movement, is it the bronchial, vesicular, or vesicular? Any additional sound, bronchi, stridor, wheezing, fine, or capitation or cross capitation, or inspiratory or expiratory. Where is it? During the sound during the expiratory phase or expiratory phase. Okay, when you do inspection of the patient, inspection of the patient. You listen to the sound by using the ears. The breath sound can be a wheeze, stridor, or gutter, or grunting. Doesn't matter, is it? Breath sound. While you auscultate, you heard bronchi, stridor, or any other sound, movement sound when you auscultate. So there's a difference between the auscultation and use the ears. So how to do it? Patient should be relaxed, breathe normally, if possible, open the mouth. A little bit, just open a little bit the mouth. Auscultate the lung. It's always started from if the bigger children from the apex, or if not, you always do the upper zone, mid zone, lower zone, and then at least one complete respiratory cycle, breathing, inspiratory, expiratory. But the best is twice. Twice. And then listen to the sound. If not audible, you ask them to take a deep breath. Kalau tak dengar saja, boleh tarik nafas dalam. You listen to the breath, bunyi sound, breathing movement first, and then you listen to the additional sound, and then you have to compare both sides. You do compare up and down. Now, what is above is down. You compare what left versus the right side, and try to listen between the inspiratory and the expiratory. They got inspiratory. You also not only listen the inspiratory and expiratory, you listen also the sound in between inspiratory and expiratory. And then after you listen to the sound, you listen to the additional sound. Is there any other sound other than inspiratory or expiratory? So you see your lung sound, breathing sound, there are bronchial breath sound here, or tracheal sound on the large airway. where the inspiratory and expiratory, you can listen, no gap, or it can be a bronchiovascular breath sound. In that one, the inspiratory is shorter than expiratory, or the bronchial breath sound, bronchiovascular, it's shown here, on the main bronchi, which is where is a large airway, and also there is a parenchyma, which the inspiratory expiratory is nearly equal, and then there is a vascular breath sound, where the inspiratory is longer than the expiratory, no gap. That's why the bronchial breath sound, the gap is there. It's easy. You already stethoscope dah. Yeah? You already stethoscope, you tak you trachea you. You dengar elok-elok. You tarik nafas, embus nafas, you find out the inspiratory is shorter than expiratory, but there's a gap in between. Stop, something stop. If you ascatate your lung, you tak you punya stethoscope at your paru you lung, there's no gap. No gap. This one is harsher than vesicular. Vesicular is parenchyma. Harsher, which one is the gap? There is no gap. There is a okay. In children, a lot of component in bronchiovascular sound, right? Because this lung is so small in children. So the component of bronchiovascular sound is become quite dominant. The smaller the children are, the bigger the children are, the vesicular sound will become more dominant. In adult, vesicular sound more dominant. Unlike in children, small children, bronchiovascular sound is more dominant because they're very near to the large airway. See this tracheal sound, like bronchial sound, and then over the trachea. Bronchiovascular sound, not far from the trachea, not far from the bigger airway, and then the vesicular sound, most of the lung field. But in children, small children, here, because the lung is small, the bronchiovascular sound can become a dominant. So auscultation, when you auscultate, what you look at, I mentioned earlier, bronchi, inspiratory, expiratory bronchi, or both, stridor, inspiratory, expiratory, stridor, or both, capitation, cause of fine. Cause capitation usually come from the secretion, large secretion. Fine capitation come from small secretion or fibrosis. You see, cause capitation. Crackle I put here because if you read some book, US book, they put as crackles. Crackles, but we use the capitation. Originated within large bronchial tubes, overconsolidation, lung cavity, excess pulmonary congestion, and bronchiectasis for the cause capitation. Fine capitation, crackle very fine. Actually, this one ada idea there, but you can go through the YouTube. You can find nicely the audio there. Usually, sudden suppression and of the sticky alveolar walls, and then at early stage of pneumonia, or early stage of TB, or pulmonary edema, or fibrosis, early stage, or the early stage, then you can hurt the fine crackles. Once it is very established, you can hurt of the frank pulmonary edema, the heart failure, you can hurt cross capitation, lung cavity, bronchiectasis, or bronchopneumonia, probably they can hurt the cross capitation. Lastly, vocal resonance. Vocal resonance, sorry, not use the letter set of your hand. You use your stethoscope. You ask patient to put 999. So this is vibration transmitted. So you put your stethoscope at the zone. You put increase resonance in consolidation, decrease in fluid or air. Compare left and right, the upper and middle zone. And then posterior examination of posterior examination is the same. Inspection, palpation, and auscultation. Same. Your auscultation. And then when you examine, as usual, any examination, remember to use the upper zone, mid zone, lower zone. When you auscultate upper zone, 2 breath, low mid zone, and lower zone. So upper zone, mid zone, lower zone. In bigger children, you can auscultate the apical, but in small children, no need. So vocal sonal also the same. Use your diaphragm. Patient with 999, upper zone, mid zone, lower zone. Okay. Vocal sonal also optional if you can do, but auscultation very important. You have to do in all patients. Even if the child is crying, and sometimes during they will stop for a while to take a breath. Nobody can cry forever without taking breath. Then you can listen something in between the crying. So you can still listen something during crying. So auscultation you have to do in all patients regardless. So other examination, posterior wall, posterior wall chest, examination of abdomen. Sometimes patient with hyperinflated lung, you need to examine the abdomen to look how much the organ, especially the liver, being pushed down, and then BCG sky. Remember to look at BCG sky. So conclusion, very important. You have to decide what is normal first. You have to recognize. If you cannot recognize normal, you cannot appreciate abnormal. So you have to practice on your friend first. Practice first until you know what's normal, and then you know if you recognize the abnormal, you will know which is. If you recognize the normal, you will know what is abnormal, where the abnormality is, when the abnormality is, how it happened, and then in each patient you have to decide your patient is respiratory distress or not. Very important, mild, moderate, or severe respiratory distress. You have to decide when you see your patient. And then presentation, very important. No point you can able to do the examination, you cannot tell us your finding. Examination, presentation is practice. The more you practice, the better you are. You always start with general examination. You can tell the patient is alert, conscious, not in distress. There's no central cyanosis or peripheral cyanosis. There's no clubbing. Child is polysystemic, not polysystemic, ping on air, doesn't matter. The examination of the throat is normal, most normal. There is and then the neck is any lymph nodopathy, enlargement lymph node or not. Inspection of the chest. Chest is a normal shape, not normal shape, move respiration or not, how the movement, the systolic respiration rate or not. And then where is the respiratory rate? And then you do your chest expansion, all normal. Any chest expansion decrease of which part, upper zone or lower zone. Then vocal frequency is what, increase or decrease at which zone. And then the auscultation entry is good, all lung field, upper zone, mid zone, or there is a lot. You can hear the wheezing, a bronchi. Where is it? Mid zone or lower zone, right lower zone, or you can at the same time like a stridor, where you stridor when auscultate, and then the sound capitation, there's no capitation, or this vessel capitation, cause capitation or not. So all this and examine posterior, same finding, or the posterior entry is decreased than the anterior chest wall, chest. So it tell you the posterior lobe is more damaged. And then examine abdomen, you noted that the abdomen decreased 3 centimeter, being pushed down because the chest is inflated. So all these findings you have to tell us, and then you only get it by practice. For interpretation of finding, if effusion, reduce tactile vocal formators, reduce chest expansion, stony dullness, reduce air entry, no added sounds, reduce vocal resonance. Is consolidation, reduce that, increase tactile vocal formators, reduce expansion, dull percussion, bronchial breathing, because it's a solid, cause capitation, increase vocal resonance, then respiratory okay. I mean that when you hear, you put something, you hear a patient do vocal resonance, you thought 9. When you listen it to your stethoscope, it seems that the sound come from somebody whispered at your ears, which you can easily, if you have cancer case, in adult, you can listen nicely. Pneumothorax, dilated trachea dilated at the side of normal lung, reduced diastole vocal fermenters, hyperresonant or percussion, reduced entry, reduced vocal resonance. Collapse of the lung, usually trachea dilated to the side of the collapse, reduced diastole fermenters, dull percussion, reduced entry, and there is probably collapse, capitation or capitation. Example, bronchopneumonia, reduce affected breathing, chest movement reduced at the side, rapid and shallow movement. This disease, example of disease, percussion, dull on the side of the pneumonic lung, increased vocal fermenters, and lot of crepitation. Asthma, reduced entry, the chest movement are reduced, but hyperinflated chest, using accessory muscles, hydrosalki noted when you observe the lung, percussion, dull, percussion, hyperresonance, auscultation, lot of wheezing, or bronchi, or there is a decreased air entry. The example findings you can get in certain disease condition. Okay, any question? Any question? Okay, I would like to examine in front of you all. It seems to be 1 hour lecture, but usually in practice, when we do a examination, I can do it 10 minutes. Finish the respiratory examination. I tak jumpa YouTube yang bagus for children, sadly. So you find it yourself. If I can get it in YouTube, then I will show to you one day lah. And I don't know why is it. I think I try to get. I think the Wi-Fi is not that good to put for video. What to do? Okay, any questions? You all question tak apa-apa? Any question?
No, Doctor. How many of you? You 3? How many of you?
If I'm not mistaken, 138, isn't it?
No, for this lecture, for your pediatric posting.
Or for the project posting, we have 34 students in total.
Okay, tak apa. Ramai. Okay, the questions. Internalize it. Hopefully you get something out of it, and see if we can see how lah. I don't know how to do a class 34 face to face. At this moment, let's see somewhere next year. Tengoklah kalau kita dah stabilize COVID, what we can do face to face. The most I can do is 8 people at one time. Okay. Tak ada apa?
Tak ada, Doctor.
Okay, okay. Tak ada question Okay, You all bila nak pergi ke tu? Suspect bila?
Starting next week on 1 November, if I'm not mistaken.
So, cek hidung bila?
According to the information I get from Kak Farah, it is on this Friday, starting at 8:30 AM. Yes.
Kat mana?
Family Health Clinic.
So, I pun kena buat sana jugalah ya. You tahu bila I kena visiting tengok you all pun I kena buat.
Oh,
Nah, you
saya
rasa apa?
baru
You
tahu.
saja kena, you saja kena. You all kan, kalau kita orang datang cuba kena swab lah hidung. Tahu tak? Bukan you all saja kena. Rasanya esok lubang. Setahun 10 kali kena, tak tahu macam mana. You all situ kalau 10 group, you 5 apa? You all ada group 4.
Yes, we have total of 4 groups.
Kita going to go twice, so 8 kali juga kita orang hidung kena swab. Setahun 10 kali. Tak tahu lah. Okay lah. Ini lost, ini hilang smell sudahlah. Okay, tak ada question finish. Okay. You faham ke? You boleh faham ke?
Faham.
Tak nampak muka you all ni. Tak apalah. Hope for the best. Okay.